Before we go through the cases, it's just a small revision of basic theory of the post-operative appearances. So nowadays everybody is performing autografts which are obtained from the patient's body. So either you can have a bone patella tendon bone graft, which is also called as BTB graft, and many times it can be a hamstring graft also, which is comprising of semitendinosus and gracilis. And then these grafts are fixed into the patient's body by means of variety of fixation devices. So this is how the bone patellar tendon BTB graft is taken, and the central 1/3 of the patellar tendon is harvested along with a small piece of bone from the patella and small piece of bone from the tibial tuberosity. And this is how it looks macroscopically. So it has got a great advantage of bone-to-bone healing, and this graft is very, very strong, but it has got its inherent problem of harvest site complications like patellar fracture. So many surgeons prefer this hamstring graft, which is obtained from the semitendinosus and gracilis. So it is cut from its insertion over the pes anserinus insertion till the myotendinous junction, and then these two tendons are looped around so as to form this 4-layered structure. So this is how the graft would look. So this is also a very good graft which is used commonly by the surgeons. Now if somebody does not tell you the history, then is it possible to identify which type of graft has been used? The answer is yes. So if you see the susceptibility artifacts like this, or if you see a defect in the central portion of the patellar tendon, then yes, you know that it is the BTB graft which has been used. And if you see a hyperintensity, sometimes fluid, within the 2 layers of the graft, then you know that it is the semitendinosus gracilis or a hamstring graft which has been used by the surgeon. Now this graft is going to change its appearance after it has been placed into the patient's body. So initially it will carry its own signal intensity from the native side, and then 3 to 4 months after the surgery has been done, then it starts undergoing a process of neovascularization, which is also called as hyalinization. This process starts about 3 to 4 months after the surgery and then continues till about 8 months to 1 year after the surgery. And during that time, the graft looks quite hyper intense on PD as well as PD fat sat images. So one should not be jumping and calling it as abnormal. This is a normal hyalinization phase of the graft. So what we should just look whether the graft is parallel to the Blumensatz's line or not. And then after 1 year till about 2 years of age, the graft undergoes a process of neoligamentization, where the graft starts assuming the appearance of a ligament, and then it would start looking bang hypointense on PD as well as on T2 weighted images. So in a nutshell, if you see hyperintensity within the graft about till 1.5 to 2 years of age, you should be cautious in calling that graft as abnormal. And if you see a hyperintense signal within the graft after 2 years of age, then you know that it is the degeneration of the graft or a partial thickness tear or a full thickness tear of the graft. Femoral tunnel and tibial tunnel, surgeons are very careful in placing those tunnels. So radiologically, there are certain ways to assess whether tunnel has been put properly or not. So we draw this line along the posterior cortex of the femur, and the femoral tunnel is located just posterior to this cortical line, or it is located at the junction of the Blumensatz's line and the posterior cortical line, or it is located at the junction of the posterior cortical line and the physeal scar. So that is the optimal position of the femoral tunnel on sagittal images. On coronal images, the femoral tunnel should be roughly at 10 o'clock or 2 o'clock positions, and it should make an angle of no less than 75 degrees with the horizontal. And just for the sake of completion, we should remember that there is something called as Bernard-Hertel grid, which is used by the orthopedic surgeons while placing the femoral tunnels. Coming to the tibial tunnel, the graft should be parallel to the Blumensatz's line, and the tibial tunnel should be located just posterior to the Blumensatz's line. Another way of assessing it is the intercondylar distance of the tibia is divided into 3 equal parts, and then the tunnel should be located anteriorly within the middle 1/3 of the intercondylar notch. And just to remember, there is something called as Amis-Jacob line, which is used by the orthopedic surgeon when they are placing the tibial tunnel. On coronal images, the tibial tunnel should be exactly at the level of the intercondylar notch of tibia. There are two types of ACL reconstructions which are routinely done. Nowadays, everybody is performing the so-called anatomical method, where we can see the tibial tunnel and the femoral tunnel roughly in the same direction. But about 15-20 years back, there used to be something called as a transtibial ACL graft placement, where we can see that the femoral tunnel, instead of getting directed posteriorly, it is getting directed anteriorly. So if you get a patient who has been operated maybe 15-20 years back, and if you see this kind of a direction of the femoral tunnel, don't jump to call this as abnormal. It is just that the method of ACL reconstruction was different during those days. So if the tibial tunnel is too much anteriorly placed, then the graft automatically becomes more horizontal, and then it is likely to get impinged against the roof of the intercondylar notch of femur. If both the femoral and the tibial tunnels are anteriorly placed, then the graft becomes very short, so it produces restriction on the flexion. When flexion occurs, then it would automatically occur at the expense of the graft integrity. And if the tunnel is too posterior, then the graft will be vertical, and these vertical grafts are very stable as far as anteroposterior stability is concerned, but they don't have any rotational stability. And then these are the variety of fixation devices. So you can have bone plugs, you can have bioabsorbable screws like this, you can have metallic screws, and you can have various kind of endo buttons. So what are the complications? So patients are going to come back either with stiff knee, or they will come back with lax knee. You can have early post-operative complications, or you can have complications related to the harvest site. So we'll start with the cases with this background. So this fellow has been operated 3 months ago. He presented with progressive swelling of the knee. He had fever, ESR elevated, CRP elevated, WBC count elevated. Surgeon was obviously suspecting infection, and basically he asked for an MR in order to confirm the presence of infection as well as to assess the extent of infection. So what do we see over here? So we can see a lot of abnormal marrow edema in the distal femur. If you have a look at the femoral tunnel, there is a collection within the femoral tunnel. The endo button is displaced out of the tunnel. Everything is looking bang, hypointense on T1 weighted images. There is a large joint effusion, and you can see collections which are tracking into the subcutaneous tissues. This is diffusion, showing everything is bright. Now, if you just have a look at this PD FATSAT images, you feel that the tibial tunnel is probably normal, and maybe the graft is also showing a normal signal intensity. So what is the next step in this particular case? What would you do as a radiologist? I think we should be giving contrast. So contrast was also given. So the marrow edema is showing abnormal enhancement. There is a lot of synovitis within the joint space, which indicates that there is septic arthritis also, and contrast is providing an additional information. The tibial tunnel, which we thought was normal on plain images, is actually showing abnormal contrast enhancement. So we know that the even tibial tunnel is also abnormal. So obviously this patient had to be put on high-grade antibiotics, the graft had to be taken out, and a resurgery was done. So when it comes to infection, one has to be a little bit careful while calling something as infection. First of all, you need to have a very strong pathological parameter backup to call that as infection, because in early post-operative period, you can have bone marrow edema, little bit of effusion, little bit of hemarthrosis. If you see collections in the femoral and the tibial tunnels, then you know that you are dealing with some kind of an infection. And as radiologists, we are supposed to tell them whether the infection is limited to the superficial soft tissues or whether it has already started going into the bones, whether the femoral side is affected, whether the tibial side is affected, because if both the sides are affected, then obviously the graft needs to come out. Now this is a spot. This is just a 1-day post-operative radiograph. What has happened? So you can see that the femoral endo button is no longer at its place. It has been displaced posteriorly. So it's important to recognize these complications. Now in this case, the graft has not filled. It's just that the endo button has got displaced, and therefore the surgeon just went inside and repositioned the endo button and fixed the graft once again. So it's important to recognize these kind of complications. Now this fellow presented with stiff knee. This is once again a spot. This patient was operated for ACL avulsion fracture, which was shown by Chaitali just a few minutes before. So these are the screws, these are the susceptibility artifact. What are we looking at? Stiff knee. So what we see here is lot of T2 hypointensity within the Hoffa's fat pad as well as in the suprapatellar fat pad. There is a lot of hypointensity and heterogeneous signal surrounding the graft. So what are we dealing with? Yes, that's a arthrofibrosis, and it is a diffuse arthrofibrosis because it is involving majority of the joint. Once again, patient has presented with stiff knee, and I pointed towards the abnormality. There is a pointer towards the abnormality. So what's that? Localized arthrofibrosis. That is also called as a cyclops lesion, and it is called as a cyclops lesion because it is supposed to resemble the one-eyed monster which has been described in either Greek or Latin literature. So when the surgeon goes inside through the anterior portal, this is something which is staring at him in the midline of the joint space. So that is the reason why it has been called as cyclops. Now, why do these cyclops lesions develop? So sometimes the surgeon leaves a little bit of portion of the native ACL fibers at the level of the tibial tunnel, and that acts as a nidus for development of future fibrosis and synovitis, which can lead to cyclops formation. So obviously now the question is, if there is a risk of cyclops formation, then why these native fibers are being left behind? But there are certain utilizations of that. First of all, these native ACL fibers will carry a little bit of proprioception from the prior to the surgery, and then that proprioception can be transferred to the ACL graft. Also, it acts as a scaffolding for the new ACL graft, and it also serves as a guideline to the surgeon as to where to drill the tibial tunnel. So that is the reason why these fibers are left behind, and sometimes you can get very large cyclops formations like this. So we are just supposed to mention the size of the cyclops lesion and leave the rest to the surgeon. Now this fellow presented 3 months post-operatively, and he had a little bit of discomfort. Once again, he had stiff knee. And what do we see here? This is just a 3 months post-operative. So graft hyperintensity, we are going to be very, very cautious. We are not going to jump and call it as a abnormal partial thickness or degeneration of the graft. This is a revascularization or hyalinization phase of the graft. But visually we can make out that the tibial tunnel is very, very anteriorly placed, and somehow the graft is looking somewhat horizontally placed. And the same thing is seen on the T2-weighted images. So overall interpretation of these images is that the tibial tunnel is too anterior as compared to what it would have been, and there is horizontal orientation of the graft. So there is predisposition for the graft impingement, and we are not going to attach any significance to the hyperintensity of the graft as of now. Now the fellow lost follow-up and came back 2.5 years later. And now what we see? Now 2.5 years later, this graft hyperintensity cannot be the revascularization phase. So this is definitely a partial thickness tear. The graft is horizontal. There is posterior convexity, there is anterior concavity, so there is an impingement of the graft. This is just the assessment of the femoral and the tibial tunnels, and we can also see a small cyclops formation over here. So this was graft impingement against the roof with partial thickness tear. This is a companion case where one can see an osteoid formation, and that osteophyte is indenting on the ACL graft. One more case, 2 years post-operative, again the lady has presented with stiff knee. Is the tibial tunnel okay, or it is anteriorly placed? It is anteriorly placed. What about the femoral tunnel? That femoral tunnel also looks a little bit low placed, and there is somewhat ballooning of the tunnels even on the X-ray. So what are the MR images telling us? So when you assess the location of the femoral tunnel, normally the femoral tunnel should be posterior to the posterior cortical line. Here it is lying anterior and inferior. So there is a low position of the femoral tunnel. As far as tibial tunnel is concerned, it is no longer posterior to the Blumensatz's line. So it is anterior, and the graft is horizontal. It is poorly seen. It is more than 2 years post-op. So obviously we are dealing with a graft impingement with partial thickness tear. Something interesting is happening on the coronal images. Can anybody spot? So normal location of the tibial tunnel is in the intercondylar notch of the tibia, and just look at here, it has been drilled too medially. So what it is doing is that within the available space of the intercondylar notch, the place of PCL is now being occupied by the ACL graft. So this ACL graft is actually causing crowding of the structures, and it is causing PCL impingement. So in this case, we had abnormal tunnel positions which led to anterior graft impingement along the roof, and because the tibial tunnel was too medially placed, it was causing PCL impingement also. So these are the graft impingements. We can have anterior notch impingement because of tunnel abnormality, small intercondylar notch, cyclops formation and osteophyte formation. If the tibial tunnel is very medial and very vertical, you will get PCL impingement, and if the tibial tunnel is laterally placed, then you will get a lateral notch impingement. What is the spot diagnosis for this? What is happening over here? This is an artifact, but what is happening within the tibial tunnel? So there is a cyst formation, it's a fluid, so it's a ganglion formation, and the ganglion formations typically occur more commonly in the tibial tunnel than in the femoral tunnels, and sometimes they pop out through the exit site and patient can present with a palpable mass. Once again, spot diagnosis. 3 years post-op. So this kind of a graft appearance is not allowed. So this is a partial thickness tear. The femoral tunnel is okay, the tibial tunnel is okay, but still the graft has undergone a partial thickness tear. Another case, more than 2 years post-op, but the graft is just not seen properly. So it's a full thickness tear of the graft. So you can have normally positioned femoral tunnels, normally positioned tibial tunnels, but still the graft can fail because of poor quality of the graft tissue. Another case. Now this fellow presented 6 months later with a lax knee feeling, and the surgeon examined him and he said that there is positive Latchmans. That means definitely there is laxity. Plain x-rays were not contributing anything, and then we proceeded with MR. Now this is just 6 months post-operative. So we can see the graft which is hyper-intense. So as I told you, a hyper-intense graft 6 months post-operative, that is less than 1.5 to 2 years, is still allowed. It can be hyalinization, it can be neovascularization. Assessment-wise, tibial tunnel is okay, femoral tunnel maybe one can say that it is slightly posteriorly placed. But can anybody spot any abnormality along the graft? Okay, I'm just going to magnify the image for you. Now can you identify something abnormal? Can you see something crescentic blackish on these images? So what is that? So what will you do next in this case to find out what is happening? CT. So this is the CT. So there is a slight hyperdense material along the graft which is seen on all the reformations. So what has happened is that the bioabsorbable screw had degraded too fast and the fragment had got displaced, and that is the reason the graft started failing. Another companion case, this fellow presented 3.5 years later with anterior knee pain, no stiff knee, no lax knee, no fever, plain x-ray is non-contributory. And on MR we can see that the screw has started popping out through the exit tunnel. And on actual images, one can make out that there is little bit of soft tissue hyperintensity surrounding the screw, which is also appearing hypointense, but there is no fever. So what are we dealing with? So in the absence of fever and in the absence of abnormal lab parameters, this is called as foreign body reaction to the screw, because of which there is surrounding soft tissue hyperintensity. This is companion case. Once again, no restriction of movements, no laxity, only knee pain, no fever, and no abnormal lab parameters. But we still see marrow edema which is surrounding the tibial tunnel, which is looking pretty hypointense on T1 weighted images. So probably there is an early intraosseous ganglion formation. So what we saw in the last 3 cases are the problems related to the bioabsorbable screw. Can I continue, Malini, or should I stop? Yeah, okay, just 2-3 minutes and move. So bioabsorbable screws are pretty popular because of the absorbing capacity, but sometimes they degrade too fast and then you can have laxity. Occasionally they can cause foreign body reactions which can mimic for infection, and sometimes they can cause intraosseous ganglion formation also. And if you get an infection in a bioabsorbable screw, then it is a nightmare for the surgeon, because all the fragmented pieces of the bioabsorbable screw need to be removed in the presence of infection. Is very difficult for the surgeon. Coming to harvest site complications, you can have patellar tendinosis and patellar thickening, which is pretty common in BTB grafts. You can have a cyst formation at the cut margin of the hamstrings, and you can have injury to the infrapatellar branch of surface now as well. And that was all about ACL. Now just talk about PCL. Now, in posterior drawer, we can see significant posterior translation of tibia with respect to femur, indicating that there is PCL laxity. And these are the MR images. So femoral tunnel is okay. The graft is looking hyperintense. Obviously, it has failed. But look at the position of the tibial tunnel for the PCL. Once again, PD FATSAT images. Look at the position of the tibial tunnel. So here we should get introduced to the concept of retrospinal line of tibia. So this posterior slope in the intercondylar notch of tibia is called as retrospinal line, and the PCL normally gets inserted in this posterior portion of the retrospinal line. So this tibial tunnel is abnormal. It has been anteriorly drilled, and in fact the surgeon has also drawn the expected location of the tibial tunnel. So these are the two techniques of PCL repair. One is called as inlay technique, where the screw is directly fixed into the tibia through the graft, and in the other method we have a tibial tunnel like this. As I told you earlier, the tibial tunnel should be in the posterior portion of the retrospinal line, and on coronal images it should be exactly in the intercondylar notch. So what is happening in this case, it is located on sagittal images in the posterior portion of the retrospinal line. But on coronal images, it is much more medially drilled as compared to the intercondylar notch, because of which the graft is showing a very acute turn, which is called as the killer turn or impingement.